Good Saturday afternoon. This is episode 2 of my PTSD series. Um, I'm going to build on and I will be reading the Shakespeare quote that I put in the short earlier this week. So let's get into it. This is from the American Journal of Psychiatry 2018. Um, Traumatic stressors have always been a part of the human experience. What is now referred to as post traumatic stress disorder was first studied in the context of military trauma during the Civil War and World War I, but most extensively in World War II. Much of what we know about the medical and psychological management of PTSD has its origins in military psychiatric approaches, and a review of these practices reveals important tenets that should be applied in current treatment for both military and non military PTSD. These practices include intervention as soon as possible after the traumatic exposure, provision for safe and supportive therapeutic milieu designed for an individual's relatively rapid return to his or her responsibilities and normal activities, and using a combination of pharmacotherapy and psychotherapy, especially exposure to the traumatic memory. A review of current guidelines for treatment of PTSD reveals that few treatments are endorsed with great certainty, owing in large part to paucity of clinical trials, particularly of pharmacotherapy. This shortcoming must be addressed to enable translation of promising discoveries in neuroscience of fear into the therapeutic advances patients need and deserve. So, we're going to take a walk back through some of the formative years of therapy based on trauma. So, trauma is not a new phenomenon, as we've explored before. We have always lived in a dangerous world and experienced the effects. In Henry IV, Part 1, in the observations of Hotspur's wife, Kate, of her husband's behavior after repeated mortal combat, Shakespeare nearly perfectly described PTSD symptoms as defined in the DSM. Hotspur's wife, Kate, goes on to say, "Tell me, sweet Lord, what is that takes thee from thee thy stomach, pleasure, and thy golden sleep? Why dost thou bend thine eyes upon the earth, and start so often when thou sitt'st alone? Why hast thou lost the fresh blood in thy cheeks, and given my treasures and my rights of thee to thick-eyed musing and cursed melancholy? In thy faint slumbers I by thee have watched, and heard thee murmur tales of iron wars, speak terms of manage or horsemanship to thy bounding steed, cry courage to the field, and thou hast talked of sallies and of retires, of trenches, of tents, of palisadoes, frontiers, parapets of ballasts, of cannon, culverin, of prisoners' ransom, and of soldiers slain, and all the currents of a heavy fight. Thy spirit within thee has been so at war that beads of sweat have stood upon thy brow like bubbles in a late disturbed stream. And thy face strange emotions have appeared, such as we see when men restrain their breath on some great sudden hest. Oh, what portents are these? So I kind of butchered that a little bit. Went into uh, modern speech, but you get the point. You see that Hotspur is suffering greatly, nightmares, depression, paleness, starting when he's sitting alone, or getting a startle response. Uh, and Kate's suffering. She's not getting her husband back that she loves dearly. Um, we uh, we see this through our life. I've seen it in my personal life. My adult children, my ex, and I have long discussed these things, the things that affected us in our marriage and in our lives. Um, and it's been good therapy to discuss these things. So I want to jump back to the American Journal of Psychiatry in 1947, uh, and a quote from Brigadier General William C. Menninger. Another observation which can be made as a result of our experience is that if intensive treatment was provided early in an environment in which the expectation of recovery prevailed, remarkable results were obtained. So, jumping back to this paragraph, what becomes apparent as we look back is the possibility that a great many of our recent therapeutic advances in PTSD were presaged by past practices. In looking back at some of the seminal writings in this area, many of them published in the American Journal of Psychiatry, we include here numerous detailed quotes from many of these papers in order to give the reader a glimpse into the wisdom of our professional ancestors. The fact that these detailed accounts appeared in print in a prestigious and influential journal also gives us pause to consider how much of the rich narrative of clinical experience is no longer communicated in the modern era of scientific discourse. This was a quote by Stein and Rothbaum, who have done a lot of research into PTSD in the neuroscience of PTSD. So here we go. In the era prior to the DSM, we'll go through some terminology and definitions. Until the appearance of the DSM-3 in 1980, many of the reports of what we would now consider to be PTSD referred to the constellation of symptoms according to the index trauma. For example, traumatic hysteria from railroad injury and rape trauma syndrome. During the U.S. Civil War, stress reactions were known as DaCosta syndrome or irritable heart. During World War I, the terms shell shock and soldier's heart and effort syndrome were used. In addition, lost my spot. I'm sorry. In addition to DaCosta syndrome, and in the United States specifically, neurocirculatory asthenia just a fancy term for generalized fatigue. Um, the British used the non-specific term not yet diagnosed nervous. So a highly technical term, as you see. The term acute combat stress reaction was used during World War II, as were the synonyms battle fatigue and combat exhaustion. And among aviation personnel, operational fatigue. And finally, post traumatic stress disorder became an official diagnosis in DSM 3 in 1980, largely in response to the need to classify large numbers of Vietnam veterans who were experiencing this syndrome. Now, why was the Vietnam War number so high? Well, a typical soldier in World War II would see about 45 days of combat during their tour. A frontline soldier in Vietnam would see an average of 212 days of combat during their tour. So you're compounding traumas, trauma after trauma after trauma. So we're going to move into World War II descriptions of treatments and outcomes. A dramatic increase in the number of articles pertaining to trauma has occurred after each war. By World War II, as described in a paper presented at the 99th annual meeting of the American Psychiatric Association, or APA, held in Detroit in 1943, the approach to treatment included individual therapy with a psychodynamic stance, with mostly silent doctor dream analysis, and discussions of transference and ego strength, but with several innovations necessitated by the sheer number of patients in need. An excerpt from this paper is as follows. Group therapy also implies a distinction in treatment. The introduction of didactic element, many psychiatrists, far from scouting this, would affirm that the power of the intellect has not received sufficient respect in psychotherapy and that it should be more fully exploited. It was pointed out how nervousness meant feelings, how feelings in wartime meant chiefly fear, how fear prepared the body for defense against attack, and how fear set the adrenaline mechanism governing. So fear is regulating the adrenaline response. Thus analyzed as physiologic defense apparatus. Fear lost much of its implication of moral cowardice for men and became acceptable in their minds. So this description of early treatment of PTSD, emphasizing the importance of psychoeducation as well as spelling out a role for cognitive interventions, foreshadows several critical elements of current day trauma-focused psychotherapies. In the 100th annual meeting of the APA held in Philadelphia in 1944, it had a prominent focus on military psychiatric, represented by several papers published in the American Journal of Psychiatry. What is common practice in the treatment of PTSD today can clearly be traced back to approaches during World War II that ushered in the more modern era of treatment. At the centenary meeting of our predecessors, they described the need for faster treatment with a reliance on pharmacotherapy. but also on combination psychotherapy and pharmacotherapy, with an emphasis on helping the patient face the traumatic memory. So this is what we now look at as exposure therapy, right? War pressures have, this is a quote, war pressures have forced us all into the search for time-saving techniques. In psychotherapy, it was natural in this dilemma that among other therapeutic agents, we should seek also greater help from drugs. From a review of the literature, as well as from our clinical experience, we have concluded that there are three principal methods of attacking the pathology and therefore the symptomatology with drugs. The object, no matter what the means, is to enable the patient to face his traumatic experience and uncondition him to it, him or her. The three methods of attack are use of sedatives to secure rest, use of intravenous barbiturates to promote mental catharsis, thereby assisting in the recall of suppressed episode. Use of drugs acting directly on the autonomic nervous system. Unquote. That was from speakers at the 100th APA meeting. This is strikingly similar to current theoretical and translational models in which PTSD is considered to be a disorder of conditioned fear and avoidance, with subsequent failure of fear extinction. Several factors contribute to the persistent, another quote, by the way. Sorry, I keep forgetting the quotes. Several factors contribute to the persistence and intensification of the fear response. To the one, more traumatic experiences, the threat of life results in markedly increased production of epinephrine, physiologic response to fear, which causes the symptoms described below and also increases irritability and external stimuli. Due to this state of irritability, milder and ordinarily ineffective stimuli result in the liberation of still more epinephrine. So what do? Resultant physical symptoms also serve to further increase fear so that both external and internal stimuli act to continue and increase the reaction. So we're in a cycle, right? We're in a problem area. The dynamic force is continuing stimulus at the cortical levels in the form of memory of traumatic experience. This reaction to their memory is, of course, fear with stimulation of the lower autonomic centers. So, and when we're talking about fear, let's remember we're not talking about a weakness or a flaw. This is something that the trauma has put into our brain, our body, our soul, if you believe in that, that we can't control that. It's natural. It's a survival instinct going back to hominoid times, right? We're going back to, this is how we stay alive. avoiding wild beasts, fighting for supremacy in nature, right? So let let's get out of our minds that fear is a bad thing. So World War II and sodium pentothal, yay boy, and other approaches to facilitating psychotherapy for PTSD. So, following the lead of Grinker and Spiegel, Heath and Sherman applied a technique in which military patients relieved the battle experience under the influence of sodium pentothal. In the treatment of battle reactions, narcosynthesis possesses considerable advantage over ordinary sedation, while both reduce sympathetic overactivity and narcosynthesis permits mental catharsis at the same time. Unconditioning is therefore hastened by the fact that revelation of the traumatic incident does not produce the usual great discomfort. So now we're using pharmacotherapy with psychotherapy. That was a quote again from Sherman and Heath. Apologies. Let's see. This formulation is remarkably close to the current explanation for proposing the use of a psychedelic assisted psychotherapy, such as MDMA assisted therapy. When the first study that used cyclosarin to facilitate the extinction of fear in humans by using exposure therapy was published, a reviewer of the study commented that it was a paradigm shift in psychiatry. However, the idea of combining psychotherapy with pharmacotherapy for trauma-related disorders has been in existence longer than the use of monotherapies. Quote, with these well-known concepts in mind, we feel that successful treatment must be directed essentially toward reconditioning the patient in the traumatic episode so that exposure to it does not produce the greater autonomic imbalance. Drug therapy, in order to be successful, must be directed toward correction of these specific alterations of physiology, thereby making more rapid reconditioning possible. Specific therapy saves time and discouragement in contrast to hit and miss therapy. Unquote. World War II, deconditioning and other precursors of in vivo exposure therapy for PTSD. So the research by Heath and Sherman and other work published around the same time describe what is known today as in vivo exposure and could be considered a forerunner to virtual reality assisted therapy. So the in vivo, yeah, I had to look at my other notes. In vivo is just facing the object of your fear in a known safe environment, clinical environment, if you will. So, quote, in this connection, we have used a short movie of an actual torpedoing to great advantage. Audio-visual aids, motion pictures are extremely useful adjuncts to group treatment and training, unquote. Modern day residential programs, including deconditioning, were described in another paper presented at the 100th APA annual meeting. The residential program discussed encompassed occupational therapy, physical activities, educational courses, vocational rehabilitation, group recreational activities, and sleep records. I've been through any number of these. Sleep records is actually a very good um, tool I found. Um, just just putting it out there. Something we can discuss in the comments, or when I go live, we can discuss them. Uh, Furthermore, most encouraging is the use of auditory stimulation in the deconditioning process of combat experience, unquote. Excerpts from this paper are presented below. Briefly, films of actual combat scenes graded in order of intensity of stimulation are shown, followed or accompanied by a record of battle sounds. I mean, remember how old this is. You're talking motion pictures and a record of battle sounds. When the technique of group discussions has been established, actual combat films of bombings, strafings, and some captured Japanese films are shown with battle sounds. After these films, pulses and blood pressure are taken. This is followed by group discussion with the psychiatrist acting as a moderator. Patients are given simple explanations of the conditioned reflex, illustrated by Pavlov's experiments with dogs. So that's the end of that quote. During the World War II period, several authors invoked conditioning to explain symptoms of PTSD. Although this did not preclude the use of hypnosis and avocation, in one of the earliest descriptions of desensitization, the authors described gradually increasing the intensity of the war movie screenings of actual battle scenes for 15 minutes per day. At first, the scenes are shown silently, only gradually as the sound introduced. Day by day, the sound is increased until full volume is reached. The authors report good results in 12 showings, and generalization of results they refer to extinction of conditioned reflex in all but one of 14 cases. So 1 in 14 became desensitized to their stressor. With the exposure therapy. Sorry, this has me thinking back to my exposure therapy. I'll talk about that at the end. So World War II, tenets of military psychiatry: immediacy, proximity, and expectancy. The tenets of immediacy of treatment and psychological first aid were described in World War II military psychiatry papers, referring to the first aid treatment of neurosis. Quote, the keynote of treatment of all acute neuroses is promptness, and the longer in the delay of treatment, the less chance is that the patient returning to duty or of regaining his former state of health. Ford treatment was first tried out by Brigadier James and Major Palmer during the North Africa campaign, an award of 100 beds was set aside for psychiatric cases. The average length of stay in the hospital was under 1 week, and the percentage of those returning to duty was quite high. For the anxiety cases or those suffering from severe exhaustion resulting from fatigue and battle stress, continuous narcosis is the method of treatment. By this means, the patient is cut from all external stimuli. The memory of the battle experience is removed, and the patient is given complete rest of mind and body. He should be nursed in a quiet, darkened room, and owing to the shortage of single rooms for this purpose in the hospital, small dormitories are set aside where 4 or 5 patients can be treated together. The hours of sleep, listen, this is pretty key. The hours of sleep are recorded on a chart, and the aim should be to keep the patient asleep for 20 out of 24 hours. The treatment may be continued from 3 to 12 days. In wartime, there is little time for detailed psychotherapy to unearth conflicts, and shortcuts to this end are necessary. So this is you're fighting a world war. So think about the immediacy of the need to get people back on the battlefield, but you're doing a study in North Africa. It's astounding to me that they did this. And the 20 hours out of 24, I get after my third TBI, they kept me asleep for about 16 hours a day. Then I was taking freaking steroids. I'll have to share a picture of me during this time. I had a daddy-daughter dance, and there's a picture of me. My head is as big as a basketball. I was 265 pounds at the time. So anyway, that's another story for another time. So let's go to World War II, introduction of hypnosis to treatment. I've never done hypnosis as a treatment. This is kind of interesting to me. I'm more interested in the use of MDMA now that I've done this research using barbiturates, and MDMA is extremely interesting. Anyway, the use of hypnosis in the treatment of acute combat reactions was proposed because of the need for rapid therapy and the fact that early drug treatments were not helpful. Both the importance of recounting and recall and a post-hypnotic suggestion for sleep were emphasized, as well as what could be described as art and science of protocol therapy. Group psychotherapy for persons diagnosed with severe and acute anxiety states was recommended in 12 sessions over 4 weeks. One of the earliest follow-up studies described the outcomes of treatment. Quote, during the first year of operation, July 1, 1944 to July 1, 1945, we treated about 240 veterans of World War II who had been discharged because of neuropsychiatric disability. Psychotherapy, usually weekly interviews, was often supplemented by group therapy, pentothal, and by social and environmental therapy, including coordination with various community resources. there's that community resources again that we talked about in episode 1, right? So that unquote that there, the authors contacted by letter 178 of 240 veterans they had treated during the first year, with 83 veterans responding. Among the 83 respondents, 55% had improved. Another follow-up report, Traumatic War Neurosis 5 years later, provides a nearly exact description of the current criteria for PTSD, including the following symptoms. Quote, intense anxiety, recurrent battle dreams, startle reaction to sudden or loud noises, tension, depression, guilt, and a tendency to sudden explosive aggressive reactions, a tendency to avoid people, fear of exposure to any type of criticism, difficulty in making decisions, and various types of sleep disturbances, unquote. I know I do have a lot of quotes in here, but it was all good stuff. In this same follow-up report, the authors detail how the experience of combat-related trauma transfers into civilian life. Upon his return to, this is another quote, upon his return to civilian life, the patient constantly re-experiences the feelings engendered in combat. The threat of annihilation and destruction was very real and imminent under combat conditions, is carried over into civilian life. Thus, the patient reacts to seemingly minor stimuli and seemingly innocuous situations in civilian life as if he were still under combat situations, unquote. In a prescient nod to the future, the authors describe what is now understood as a gene by environment interaction. So what is that? It's your genetic makeup reacting to the environment around you and how your genes have somehow gotten this program right of this response. And this is what doctors have been trying to unlock in us who have been in treatment for PTSD. So they go on to delineate what we know today as exposure therapy and to indicate about 20 sessions were usually required. Quote, it is apparently necessary to have a combination of accidental circumstances superimposed upon a receptive soil in order to precipitate an overt chronic traumatic war neurosis. Because of the importance of the establishment of a firm, deep relationship between the patient and therapist, the use of intravenous narcotics and hypnosis has gradually diminished in our clinic. We have found that abrogation of traumatic events occurs without intravenous narcosis or hypnosis in the course of regular interviews, unquote. Now we're moving to the Korean War, the Forgotten War, the one that hardly anybody talks about, which is a shame. It was a brutal conflict. So, Korean War advances in combat psychiatry. In a paper presented at the 108th APA annual meeting held in Atlantic City, New Jersey in 1952, the authors asserted that the Korean War and combat psychiatry continued the concept developed in both world wars, with that combat fatigue should be treated as near the scene of combat and as quickly as possible. As far forward in the division as practicable, fatigue is dealt with by proper rest with or without sedation. The authors engage in an interesting discussion of the dilemma of sending service members back to the front. So it's pulling a Patton move, right? The guys in the infirmary with shell shock and Patton smacking him in the head and ordering him to get back to the front, right? Not necessarily for treatment reasons, but it seems to follow. Quote, perhaps one of the greatest difficulties in combat psychiatry lies within the physician himself, and this difficulty increases with his personal distance from combat. The physician is the victim of his own attitudes, motivations for the practice of medicine, training, and ego ideal. It is easier to say, thus man should never have been drafted, than to help him adjust to his duties. It is easier to send a frightened young soldier who reminds one of oneself or one's own son to the rear than to return him to combat duty. One's own feelings of guilt over returning another to combat duty, more dangerous and arduous than one's own duty, make it difficult for the psychiatrist to function effectively and without anxiety. It is quite necessary for the psychiatrist to work these things through so that he may effectively and happily carry out his chosen work or the work that has been chosen for him. It may seem unkind to require further duty of a person who is anxious and uncomfortable, but the greatest psychiatric medical evacuation of a patient who has not yet performed with a degree of honor required of him by both his superego and the community as he sees it, aiding him to burn his bridges behind him and making his guilt irrevocable, unquote. So a couple of things here. We in our little sector on the live end have heard of late about psychologists and psychiatrists having a higher than normal suicide rate. Well, there's a reason for that. They have, just as quoted, this burden, right? They take on their client's burden, and they had the dilemma that I've either got to send this person back to the front and put them in more danger, or send them to the rear and have them deal with this super ego driven ideal of a soldier or of a man, of a woman. So the psychiatrist has a problem dealing with these things, and then the soldier has a problem of going to the front or being sent home. I know I did not pursue a career in psychology because of internship and hearing the stories of multiple people and taking that on in such a heavy and caring way because you have to have empathy, right? Um, it, it, I could see where it could drive people to that end. And it's sad. It's not to be made fun of. It's not to be used as a sword and shield, right? And or as a excuse not to seek therapy because therapists are somehow weak. Anyway, I'll get off my soapbox on that one. Um, so I don't know if I ended the quote on the irrevocable guilt, but that's the end of that quote. So, in a review article published in the American Journal of Psychiatry in 1954, Glass summarized 4 state of the art basic principles of military psychiatry. Treatment should be as near the battlefront as possible. Treatment should combine simplicity and brevity. Psychiatric staff should create a therapeutic atmosphere that reflects positive motivations, and that psychiatrists should identify with the needs of the combat group rather than the individual. So this is where we get that conflict, right? Um, so even in this, we have brevity in the Korean War, but actually the Vietnam War is going to be a little more brief. Vietnam War, uh, combat psychiatry in the face of overwhelming mental health needs. So during the Vietnam War, your wartime, we're looking at 1955 to 1975, not all inclusive for us. The principles of immediacy, proximity, and expectancy were continued in the practice of combat psychiatry, according to Block. They asserted that the combat veteran, quote, should be treated as soon as possible after they develop incapacitating symptoms. They should be treated as close to their own unit and comrades as possible, and their treatment is undertaken and maintained with the expectation that they will respond favorably and return to duty, unquote. However, at that time, the capacity of mental health personnel was inadequate to meet the needs of the military, with fewer than 20 Army psychiatrists and few social workers and fewer personnel still for the Navy, Marines, and Air Force. Quote, a combat soldier who breaks down in battle or a non-combatant soldier who develops symptoms in an outlying area is taken to the nearest of these outposts where one of the specially trained medics ministers to him. He usually takes him to a quiet place, urges them to review the traumatic events, reassures them, and lets them sleep overnight after a hot meal when possible, recommends medications to the general medical physicians there when appropriate, and then returns the soldier to duty the next morning, unquote. So you've had a debilitating event um, occurring, and you get a good night's sleep, essentially, and then you return to combat. Now, I can kind of relate to this when we were invading Iraq. Um, we were doing reconnaissance, and then the fighting started, and we started moving up towards Najaf. Um, and I think, man, once we got up to Balad, I bet I slept 12 hours. My command let me do it. It was a refreshing thing to do. Um, I get the need for sleep, but I mean, people like Top, Jeff, uh, Hippie, Josh, Wally, they were doing turnarounds, man. I don't, and I've never talked to them about it, but I don't think they probably were given that kind of opportunity to just crash out for 12 hours plus, you know. Um, but we'll continue on. That was the end of that quote after the next morning. Uh, so now we're going to do a little bit about something that people tend to like to ignore, and that is rape trauma. I know that word is verboten, but I think it's important to talk about it as it is, right? So in 1974, continuing in the pre DSM 3 tradition of describing post trauma reactions in a trauma specific manner, a revolutionary article on rape trauma syndrome was published on the basis of qualitative analysis of interviews with the 92 adult female survivors. Burgess and Holmstrom identified 3 reactions and different treatment for each reaction. For the survivor with typical rape trauma syndrome, they recommended crisis intervention counseling, which was clearly not considered psychotherapy. For women with compound reactions, additional professional counseling was recommended. They went on to assert that providers treating survivors who did not disclose the rape, termed silent rape reaction, must be on alert to, this quote, must be on alert to indications of the possibility of rape having occurred. They defined rape as an act of violence, as it should be, rather than a sexual act, which was deemed revolutionary at the time. The long-term process reorganization stage was characterized by almost one half of the women who were changing residences and seeking social support, but also experiencing more PTSD-like symptoms of nightmare and traumatophobia. Um, Sandor Rado coined the term traumatophobia to define a phobic reaction to a traumatic situation. So now we're getting into the DSM era of treatment of PTSD. The designation of PTSD as an official diagnosis in DSM 3.1 ushered in the modern era of PTSD treatment. Psychodynamic conceptualizations. I shouldn't write words I can barely say. And treatment continued, but controlled clinical trials testing them were and continue to be rare. Cognitive behavioral therapy, or CBT, quickly became one of the first line treatments for PTSD. CBT was well suited for PTSD. PTSD is characterized by anxiety, avoidance, and cognitive distortions, and CBT has well delineated techniques with proven efficacy for such problems. CBT is generally short term, problem focused, and readily manualized for teaching and dissemination. So, development of trauma focused psychotherapies. One of the first post DSM treatments developed for survivors of rape with PTSD was stress inoculation training, which is a package of anxiety management techniques and became the basis for cognitive processing therapy. However, these early studies aim to alleviate fear and anxiety in rape survivors rather than PTSD specifically. Cognitive processing therapy was later adapted for active duty and veteran military patients with PTSD. Techniques in which patients were assisted in confronting the memory of a traumatic event in a therapeutic manner were some of the first tested in randomized controlled trials for PTSD, which naturally grew out of the conceptualizations of PTSD. Possibly the first randomized controlled trial published actually referred to patients as having PTSD, applied these techniques to Vietnam veterans. And this study was soon followed by a study of female rape survivors. This approach was used in the development of one of the first published treatment manuals specifically for PTSD, although initially with a focus on rape survivors and later for PTSD more broadly. A 2008 Institute of Medicine report established that trauma-focused treatments had more evidence for their efficacy in the treatment of PTSD than any other intervention, including 2 medications approved by the Food and Drug Administration, which some of us would recognize, sertraline and paroxetine. Soon after the publication of the report, the U.S. Department of Veterans Affairs began the first national dissemination effort to initiate empirically supported treatments for PTSD, training VA providers nationwide in 2 evidence-based trauma-focused therapies: prolonged exposure therapy and cognitive processing therapy. Recent research has shown although cognitive processing therapy can be delivered in a group format, its efficacy is better when administered individually. Virtual reality exposure therapy, which is a higher tech version of the techniques of showing film of combat as described by Schwartz earlier on, was first administered to Vietnam veterans experiencing PTSD in the late 1990s in order to provide a potent stimulus for exposure therapy in this population, which comprises many individuals with treatment-resistant PTSD. Virtual reality therapy has shown efficacy among veterans of the war in Iraq and Afghanistan. I will respectfully differ with the study on this. I'm putting it out there. Again, I think it depends on the person. I recommend trying it as it is an effective means to some people. I think what I went through with my exposure therapy was a bit extreme. And so absolutely decide for yourself, but make sure that more harm isn't being done. And I'll talk about that in a little bit, about my experience, personal experience. This is just me, and it's probably an oddest thing with me, that it was so bad for me, but um, it could be any number of factors. Anyway, let's keep going. So, health service delivery for PTSD. In the VA healthcare system, specialized PTSD clinical teams were established for outpatient service delivery. These PTSD clinical teams have typically included a multidisciplinary group of clinicians and other relevant professionals: psychiatrists, psychologists, social workers, and chaplains, capable of providing a broad set of treatments and services. More recently, evidence-based treatments to patients with PTSD. Although there has been some research assessing the duration and intensity of this type of outpatient specialty care, to the best of my knowledge, there is no evidence showing that the specialized care is superior to or more cost efficient than general mental health outpatient care for PTSD. Although the fact that PTSD clinical teams are equipped to deliver evidence-based psychotherapies argues in favor of retaining the structural organization and the associated therapeutic expertise of its team members. Some recent examples of specialized PTSD mental health programs in the private sector include the Cohen Military Family Clinics and others. In the active duty military setting, the Army adopted structural changes in 2010 that harken back to World War II practice of providing care geographically and temporarily proximate to the battlefield. In addition to increasing the number of mental health personnel and standardizing the services they provide, the Army has been embedding small teams of mental health professionals within all operational or combat brigades, fostering enhanced access to greater coordination with unit leaders. In an interesting long-term follow-up of a study of combat stress reactions, casualties from the 1982 Lebanon War, Israeli soldiers who received frontline treatment fared better 20 years later than those who did not receive treatment on the front line. And as I have pointed out in episode 1, the Israeli soldiers are kind of unique in that they are fostered back into the community, right? They have their rabbi on the front lines with them. They pray. They are then fostered back into the community, not just brought back in and you're just a part of the crowd. You melt into society, right? You're important to the community that you live in. So a key observation is that not every new intervention must be followed by years of outcomes research before it can be considered actionable. Careful examination of the utility or lack thereof of similar interventions deployed in previous eras may be sufficiently informative to permit practice changes to occur in real time. Although once implemented, these changes should be evaluated prospectively as recommended in a 2014 Institute of Medicine report. So, as Winston Churchill noted, the better one understands history, the more one can project into the future. So, where are we at? We're at pharmacotherapy for PTSD. Most pharmacotherapies studied for PTSD have been antidepressants, tried partly on the basis of high comorbidity between PTSD and major depression, but also partly on the basis that antidepressants were almost the only credible drug candidates available for clinical trials for PTSD. Early published research suggests possible utility of tricyclic antidepressants, desipramine, and monoamine oxidase inhibitors. I promise I practice all these words before I started recording this, but evidence was scant and use of these drugs for PTSD has not become prevalent by the time selective serotonin reuptake inhibitors, or SSRIs, entered the market in the mid to late 1980s. Some have argued that these medications, possibly tricyclic antidepressants and desipramine in particular, deserve further study as treatments for PTSD. 1 second, please. All right, sorry about that. As a result of the first large-scale randomized controlled trials for PTSD drug-related treatment, the FDA approved sertraline and paroxetine for PTSD in 1999. These were the first and last drugs to obtain FDA approval for the treatment of PTSD. Many other drugs were studied, mostly in relatively small scale studies, although some of these studies were bona fide randomized controlled trials. A 2006 Cochrane review reported that 35 randomized controlled trials had been conducted involving 4,597 participants. The report concluded that SSRIs could be considered first-line agents in the treatment of PTSD, but that there was a need for more effective agents. More recent interviews have been more sanguine, pointing toward the modest effect of SSRIs and serotonin norepinephrine reuptake inhibitors for PTSD, and the need for more research in this area. With the exception of venlafaxine, for which there is solid evidence for efficacy for PTSD, although without FDA approval, no substantial evidence of efficacy exists for any drug subsequently studied. There are also examples in which drugs widely used and thought to be beneficial for some aspects of PTSD were subsequently shown to be ineffective for global PTSD symptoms. When amelioration of these symptoms was the primary outcome, probably the best example is the VA cooperative study of risperidone for PTSD, wherein risperidone failed to achieve efficacy on the primary outcome, total score on the clinician administered PTSD scale, but showed benefits of hyperarousal and re-experiencing symptoms as well as for insomnia. Another more perplexing example involved prazosin in the treatment of PTSD for nightmares. Prazosin not only performed well in small randomized controlled trials and was used extensively in VA facilities and elsewhere, expanding nationwide from its origins in the VA Puget Sound healthcare system, but in an iconic study of active duty personnel with PTSD, it outperformed placebo to the extent that the study was halted early. Yet, in one VA cooperative study, prazosin failed to outperform placebo. Reasons for these discrepant outcomes may have more to do with characteristics of the patients included in the VA cooperative studies, ergo, high illness, chronicity, and prior drug treatment failures than with the properties of the drugs themselves. Highlighting the importance of stratifying by such clinical characteristics in future PTSD trials, another imperative is the need to test the efficacy in randomized controlled trials of drugs that are currently widely used for PTSD, ergo trazodone, without any empirical basis. So, combination pharmacotherapy and psychotherapy. Again, going back to the treatment recommendations made at the 100th APA meeting in 1944, many patients with PTSD are treated with combined pharmacotherapy and psychotherapy. Yet randomized controlled trials of combination therapies have rarely shown them to be more effective than monotherapy. Combining sertraline and prolonged exposure was only more effective than sertraline alone among patients with weak medication responses. Similarly, adding paroxetine to prolonged exposure therapy was shown to be more effective than adding placebo to prolonged exposure therapy. So, to my knowledge, in doing research, there has been only one randomized controlled trial in which combination with an SSRI was more effective than placebo, plus prolonged exposure therapy, and this was among individuals who experienced PTSD after surviving the September 11th, 2001 attack on the World Trade Center. Combining more novel compounds with psychotherapy has mixed results. D-cycloserine has generally shown weak effect when added to psychotherapy for PTSD. There is some evidence, woohoo, and enthusiasm for combining MDMA and psychotherapy for PTSD. Again, very similar to what was described almost 75 years ago. But confirmative results from randomized controlled trials are still pending. So what are the treatment guidelines? The treatment guidelines, according to the APA, practice guideline for the treatment of patients with acute stress disorder and post-traumatic stress disorder was published in 2004 with a guideline watch published in 2009. But the guidelines have not been further updated and should be. The most recently updated treatment guidelines for PTSD are the APA 2017 clinical practice guideline for treatment of PTSD, and the VA Department of Defense via 2017 clinical practice guideline for the acute management of post-traumatic stress disorder and acute distress disorder. So the American Psychological Association guidelines strongly recommend a variety of cognitively and behaviorally oriented psychotherapies, including CBT, cognitive processing therapy, cognitive therapy, and prolonged exposure therapy. Acknowledging the guideline development panel for the treatment of PTSD did not evaluate trauma-focused therapies separately from those that are not trauma-focused. The panel suggested a lower level of endorsement than strongly recommended. The use of brief eclectic psychotherapy, eye movement desensitization and reprocessing, and narrative exposure therapy. The panel also suggested the following drug treatments: fluoxetine, paroxetine, sertraline, venlafaxine, and the VA Department of Defense guidelines strongly recommend individualized, manualized, trauma-focused psychotherapy as first-line treatment in non-trauma-focused psychotherapy or medications. Again, the same medication list as I just laid out. When the former is not readily available or preferred, these are the only two strong recommendations. So we're getting close to the end, I promise. Future directions for PTSD therapeutics. So I hope, and we as a community, I think, hopes we as a community of people with PTSD and other type trauma disorders hope for a future that PTSD is the subject of many more trials and larger trials large enough to support strong therapeutic recommendations. Update your dang books, people. Study more. I mean, I'm talking to the APA and the APA. We're people out here and we're just getting kind of tossed around, right? I mean, it's great seeing the history of how things developed. It's great hearing about therapies and cool stuff like MDMA and just, man, boom. It's so many things that excite me about this and makes me hopeful for, if not a cure, a sharp decrease in symptoms, education before we put people in situations such as war, SA. I mean, you never prepared for that, right? I really can't speak on that too much other than what I've studied, and I'll put out what I can on that. But anyway, So we as the community hope for a future in which PTSD is the subject of many more trials. Trials large enough to support strong therapeutic recommendations. The field is not only in dire need of comparative efficacy trials of existing treatments, perhaps a sequenced treatment of alternatives to relieve a PTSD study, but also trials of novel therapeutics. We should study older drugs that held promise. Uh, Desipramine and MDMA, but were insufficiently studied at the time. And we should follow up on drugs that are marketed for other indications and have theoretical rationale for utility and preliminary promise of efficacy. Methylphenidate, although the benefit of adding D-cycloserine to augment exposure therapy for PTSD and other anxiety-related disorders has been determined to be very modest at best. There is considerable reason for hope that alternative pharmacological approaches to boosting the effect of exposure-based therapies will prove to be useful. So clearly, we need to understand better the neurobiology of PTSD to develop new compounds that specifically target these neurological mechanisms and to determine for whom particular treatments are most likely to be efficacious. In the past decade or so, there have been remarkable advances in preclinical and clinical neurosciences. With the traditional translational promise for PTSD, although beyond the scope of this article, it is most particular to increase the understanding of the molecular biology of fear, learning, and fear extinction as extremely promising gateway to drug development for treatment. I'm sorry, that confused me because I misplaced the quote, the reference of that quote. It is Stein and Rothbaum again. Sorry about that. I'll put all of the references and stuff in the community page after I post this, but apologies for having a brain reset momentarily. So, furthermore, we need to develop new treatments or modify existing treatments, pharmacological, psychological, that are effective and acceptable to patients with PTSD. So, a promising delivery method for veterans with PTSD from Iraq and Afghanistan is the intensive outpatient program model that is being implemented across the Warrior Care Network, which is funded by the Wounded Warrior Project. I know. Patients are treated daily for 2 to 3 weeks in a cohort model, receiving intensive evidence-based treatment, either prolonged exposure therapy or cognitive processing therapy. In daily, individual, and group sessions, again, this is not actually an innovative concept, since a particular type of program was described by Schwartz in 1944. To date, the response and retention rates for this model are impressive, exceeding rates reported for any published clinical trial. Approximately 95% of patients with PTSD complete the program with approximately 20-point decreases in scores on the PTSD checklist for the DSM-5. However, Randomized controlled trials are needed to demonstrate superiority to other less intensive programs, the modes of service delivery. So, because PTSD occurs after onset of identifiable traumatic event, secondary prevention is a goal of ongoing and future research. We should pay heed to lessons of the past and that emphasize the need to intervene early. Whereas the data are somewhat stronger for early psychological interventions, except the critical incident stress debriefing, which has been shown to be effective for some individuals, even harmful than for early pharmacological interventions. Early escitalopram, hydrocortisone, or oxytocin, administration. The evidence for base for both needs to be expanded for them to be approximately applied in clinical practice. Propranolol studied to prevent PTSD was a disappointment, although it has shown some promise when used as a putative reconsolidation blocker during trauma memory reactivation. Because aspects of PTSD can be molded and mapped to increasingly better understood neuronal mechanisms, learning and memory condition fear, PTSD has the potential to lead the way in the understanding of the development and mechanisticality based treatments and preventative interventions for mental disorders. So that is it. Um, so um, I want to give a special shout out to Dr. Stein and Emory University for help with this paper that I could present to you guys. Sorry for the mess up on the words. To my experience with exposure therapy. So early on after my medical retirement, they put me, Atlanta VA put me in a test group cohort, I guess, at Emory for virtual reality based virtual reality based immersion therapy. That's what they were calling it then. But so they took my 5 worst combat experiences, turned them into virtual reality, 8 hours a day of watching them over and over and over again for 8 weeks. And again, I will say this is probably more me than anything, but for me, it was too much, and it made me significantly worse. What worked better for me in the cognitive therapy side was journaling and ha so I have a team. I have a psychiatrist and I have a psychologist. I've been blessed to have the same ones at the VA for the last 5 years. Um, and I've held them consistently for long periods of time. It is it's helpful that the Atlanta VA has Emory there, so doctors generally stay longer, and I have more access. So the journaling, the sleep journaling has been very helpful. Hanging out with the guys and you guys on streams, tremendously helpful. Um, and my exposure therapy is to get out and be around in my community, you know. Since I moved down here, um, getting out, getting to know my community, and having a real good time doing it. And it truly is therapeutic. So I've been going for an hour and a half. I am going to cut it here. I hope you all enjoy. Hit, hit the like, dislike, subscribe. Please comment. Let's have a dialogue. I know this is long and boring and technical at times, but I think it's important to talk about it in this way. I'm going to see about being able to go live, and that'll help, I think. You guys give me suggestions, any ideas, any things you want to hear about, let me know. All right. Y'all be good.